here. And make yourself go through it as you are studying. Here I would say throw out the learning objectives. It's very short. Pretty much I want you to know what's in this handout. If you look on page 4, I gave you a table. The table gives you almost all of them, not all, of the vasopressors and the inotrope. And it shows you doses. You don't need to know doses, but one thing I think you should look at it as, and this is what makes these drugs hard, is that there's variable response to receptors depending on concentration. So what you get at low doses will not be the same as you get with high doses. So you notice that dopamine is a big one. At low doses we can get great renal effects, but as you go up, you get different effects on the heart. So I've tried to note those off to the side with clinical effect on cardiac output and peripheral resistance. The other thing to look at next is receptor sensitivity. You see the same thing. You see changes in receptivity as you change dose. If you look at epinephrine, at low doses, it is primarily beta-1, heart. So if you go across, you see great increases in cardiac output, right? You would expect that. It's an inotropic, chronotropic agent. As you push the dose, though, what starts to show, what gets stronger? Your alpha, vasoconstriction. So if you've got somebody who's hyperperfused, then you would want to use this drug. That's why it's used in second-line vasopressor, is because of that vasoconstrictor. Look at norepinephrine. You can see why it is the preferred vasopressor. It's huge. It's the most significant in terms of alpha activity, alpha-1. Okay, so that's those. If you go over, you see pharmacologic effects. So VD is vasodilation, VC vasoconstriction, INT is inotropic effect, CHT is the chronotropic. And then clinical effect is in that very last column. You don't have to memorize this. I'm using it for you to show you relationships, comparisons, help put a visual to what we're going to talk about in the text. Okay. So let's go back to the first page. So drill this into your brain about alpha adrenergic. What are they? If you activate them, where are they and what do they do? They're in the vascular wall. If you stimulate them, they constrict. So one of the major tones on your arterial bed is your sympathetic nervous system. And the main neurotransmitter is norepinephrine. Okay? So when you all, as soon as I said, let's take a break, and you popped up, none of you fainted. Why was that? Because your brain can send messages very quickly, constrict your blood vessels because you're still young and you don't have a lot of calcified vessels, and keeps that blood coming back to the heart, which then can get it to the brain, right? Beta adrenergic, beta-1s, heart. They increase inotropy, which is what? Force of contraction. If you get to that word and you're like, what does that mean? Don't just ignore it. Make yourself look it up. Inotropic effect. And chronotropy. Chronotropy is what?
Heart rate.
Chronos, Greek, time. Chronotropy. Okay. So, rate. Minimal vasoconstriction. But if you stimulate beta-2s in the blood vessels, you can get vasodilation. We talked about that. Primarily, those are in those blood vessels in the skeletal muscle. Make sense? We need to, if you're going to get to the bathroom, you've got to have blood coming through there so oxygen can be delivered and you can keep moving. Dopamine. Dopamine's hard because it's very weight-based. It's very concentration-based. And it's everywhere. Renal, splanchnic, coronary, cerebrovascular beds, vasodilation. But just to drive you crazy, there's a second type that causes vasoconstriction because it causes norepinephrine release. Keep that in mind. What I want you to know are the big things about these. These are hard drugs to use. When people have to have these drugs, they are sick. And they are going to die if nothing's done, usually. Okay? Septic shock, hypovolemic shock, cardiogenic shock. So they're all hypoperfusing tissues, right? And if you don't correct something, most of them are going to die. So these are major guns. This will take some time if you ever use them. Because they are so variable in terms of how people respond. So your main target with them in terms of, because we're using them mostly for people who are not perfusing, right? For whatever reason. They got lots of bacteria, they're producing toxins, and they're vasodilating everywhere, right? So it's a toxic situation. Or it's cardiogenic. Heart can't pump. You can't pump, can't get blood out, can't oxygenate, so you're hyperperfusing every organ, right? And then volume type of shock. You've lost blood, you're losing, you're third spacing lots of fluid. So in all those cases, you can't get enough blood to the tissue. So all of this is mostly geared towards keeping perfusion to organs, right? So based on the type of shock you're dealing with is what drugs you're going to use. Whether you use an inotrope to increase force of contraction, like in cardiogenic, or a vasopressor like norepinephrine in septic shock. Okay? So look for those big things as you go through. All right. These determinants. What is MAP? Mean arterial pressure. What is it a surrogate marker for? What are the determinants of mean arterial pressure? Cardiac output times total peripheral resistance or systemic vascular resistance. Okay. We determine it by measuring what? Systolic and diastolic blood pressure. Okay. So if we're looking at blood pressure, what is it a surrogate marker for? Surrogate meaning what? If you got a surrogate mom, what are you doing? Using something else to get a baby. Okay. Make it more. So a surrogate marker it's a surrogate marker for tissue perfusion. Okay? Because what's the goal? You want your mean arterial pressure above what? What's the goal? 60. Above 60 tells you that usually the tissues are being perfused. Now in some of those shocks, I think they up it to like 65 is the goal. So the drugs you're using, you are going to be monitoring that mean arterial pressure in order to make sure you're perfusing the tissues. Okay? So so start breaking it down. What are your determinants of cardiac output?
Heart rate.
Heart rate times what? Stroke volume. What determines stroke volume? What is stroke volume? Amount of blood that is pumped out with each beat, right? Okay, so what would determine that? Afterload. Afterload meaning what? How much pressure am I having to go against to get blood out of the ventricle? Okay, what else determines? Say it loud. Just shout it out. If it's wrong, you're braver than most of the people in here. Preload. You got to get some up there before you can push it out. Okay, so preload. So if you're vasodilated everywhere, if you're hypoperfusing everywhere, what's your preload like? Low. Okay, what's the last thing that does stroke volume? You just, you've got, this is not hard. Think about it. Stroke volume. I'm trying to get an amount of volume out every time the ventricle beats. So what has got to be part of the equation? Contractility. Make yourself think through that. So what drugs will increase contractility? Inotropes. Inotropic effect is force of contraction. I know this at such a superficial level compared to cardiologists, but so you can do it too. Just force yourself to go back through. If you go, I don't know that, I don't know that. Look it up and make yourself go further. Okay, what are the determinants of heart rate? Just sitting there, what is regulating your heart rate? Sympathetic nervous system, we talked about this with atropine yesterday. Sympathetic, and parasympathetic. It's the balance of the two. What determines total peripheral resistance? Say it again. Yes, but more than that. It is vasoconstriction. What determines it? How much what's another way to talk about a constricted vessel?
The diameter.
Okay, so if the diameter, what's that go to? Resistance. So it's the size of those vessels. It's the summative size of all of those vessels that blood is going through. Everywhere. Okay, so go over those and over those and over those in those receptor types as well. Okay, so let's come back to the what determines blood volume? What will, okay, that's you. What is going to determine what you do with that water? What system is in charge? Renal angiotensin syndrome. Regulates what two big things that will impact volume? Sodium and water. Okay. So keep dragging those things in. You ought to keep asking yourself why until you have the answers. Okay. All right. So in the middle, route of administration. Usually you're going to use a central line. If you extravasate a vasopressor, you kill off all the tissue that has been infiltrated with those. So usually you're going to use central lines closer to the heart. You regulate it more readily. You can give it peripherally, but you're going to do that usually until you get a central line. So if y'all talked about central lines, if I talk about central lines, it makes sense? You know what a central line is? Okay, good. Tachyphylaxis, we talked about this before. You keep beating receptors, eventually they don't respond as much anymore, right? So all of these drugs you can experience that with a patient. And you're going to keep titrating them up until you get that mean arterial pressure where you want it, or a side effect occurs. Okay. So vasopressors, these are very potent vasoconstrictors. So which of those receptors are they mostly going to be working on? Alpha 1. They're indicated when your mean arterial pressure is less than 60. Okay, makes sense now that we've talked about it. Or you've got a decrease in systolic blood pressure that exceeds 30. So systolic pressure is also an indicator of perfusion. It's just not as sensitive. But if you can't measure the mean arterial pressure, then you can look at systolic. The other would be is look at the organs. Okay? If your kidney starts shutting down, it could very well be because it's one of the organs that's going to do it. It's going to stop working and letting go of fluid if you're hyperperfused, right? Yes. Complications of vasopressor therapy include hypoperfusion. You've shunted it away from one thing into another. Dysrhythmia. So they're very potent vasoconstrictors. So in alpha, some of them have beta effects as well, so they can drive the heart into a different rhythm. So that's where the dysrhythmias come. Ischemia. If they're vasoconstrictors, they can constrict the little vessels in the heart. So you can get that. Remember we talked with epinephrine. I told you I'd seen it in older people where they give epinephrines, particularly for asthma. You get an MI because you've now vasoconstricted their heart vessels. Peripheral extravasation results in skin necrosis. The skin, you give it so much vasoconstriction, it gets ischemic and it dies. And hypoglycemia. This affects mostly the release of insulin, so their blood sugars go up. And you're also hitting the liver, and with epinephrine, sugar gets released. Glycogen gets broken down, glucose gets released. You don't release as much insulin. Okay. Norepinephrine. So Levophed is the brand name. It acts on alpha-1, which means what will be its effect? Vasoconstriction, and it's a beta-1, so that means it's what? Heart. Inotrope, chronotrope. So a potent vasoconstrictor with a modest increase in cardiac output. So you can get a reflex bradycardia. So what happens there is that you get that mean arterial pressure up, stress in the system goes down, heart rate goes down. You don't see that very often, but that's what's happening. Mild chronotropic effect, it gets canceled out, heart rate remains the same. That's what drives you crazy about this, because there's too many little forces that are in there to predict it fully. It's the preferred vasopressor, or initial, I should say initial, for septic, cardiogenic, or hypovolemic. So across the board, unless you have a reason not to use norepinephrine, this will be your first vasopressor. It constricts arterioles at all infusion rates. So if you flip back to that chart and look at norepinephrine, it's pretty much a wide range of dosing. So you start low and you just titrate it up until you get that mean arterial pressure where you want it. And if you look over to the end, you see cardiac output, minimal effects, but CVR, which is one of your big determinants of mean arterial pressure, that's what's going to raise it up. Heart rate and cardiac output remain fairly constant, wide range of dose. Questions? Okay, epinephrine. Dose dependent. Look at the chart. Look at the table. Epinephrine, you see, has certain effects at low doses. Higher doses, you get different effects. That's the one I was showing you. Low dose, you get mostly beta-1 effect. You keep pushing it up, and you get alpha effect. So early on, you're going to get increase in cardiac output because you increase stroke volume. And heart rate will go up also. And then your alphas take place, and so your peripheral resistance is going to go up. If they're hypotensive, hypoperfusing, that should reverse it. So let's see, we talked about low doses. So let's go back over that. So low doses increase in cardiac output because of beta-1 effect. Inotropic, chronotropic. So go back if you're going, okay, heart rate goes up, stroke volume goes up. Force, because it's force of contraction, right? Stroke volume, the impact is from contractility. Heart rate, both of these go up, cardiac output goes up. So you do have adrenergic effects, but the beta-2s can, because of the size of those beds, can be the prevailing effect. So it may be that they are getting vasodilation. So the results increase cardiac output, decrease in systemic vascular resistance, variable effects on mean arterial pressure. That's low dose. High dose, the alpha adrenergics are predominant. So that's where your SVR, your systemic vascular resistance, is going to go up, so your mean arterial pressure is going to go up. So initial vasopressor of choice in anaphylactic. You know this, right? Because we've talked about it so many times with anaphylaxis, so you know this. You just have to kind of mark it into that category. Can be added on to norepinephrine, because they have differential effects on the different receptors. So if norepinephrine is contraindicated, think epi, or as an add-on. So increase in heart rate, you can see tachyarrhythmias. You get atrial arrhythmias. You keep driving it enough, then you'll get little errant arrhythmias pop up. And ischemia, because you can exceed the oxygen consumption demand can be too high for the muscle, and how much the blood vessels can deliver. Make sense? Mm-hmm. Okay. All right. Phenylephrine. It's a pure alpha adrenergic constrictor. So it doesn't drive the heart, no chronotropic or inotropic effect. Okay, just vasoconstriction. So its effects for mean arterial pressure are going to come from vascular resistance. So if you're hypotensive and you don't need the heart so much, or you want to avoid effects on the heart, that would be the drug to use. So it's reserved for patients where you can't use norepinephrine because you've got arrhythmias that are causing trouble or they have failed other therapies. Initial vasopressor with tachyarrhythmias won't let you use norepinephrine. Okay, because you've got that just alpha effect. So think about it. If I drive beta receptors hard enough in the heart, I'm going to get arrhythmias. If there's already myocardial dysfunction and they have atrial fib, atrial flutter, tachycardia, they're tacking along too high, then this is a drug to consider. It may decrease stroke volume and cardiac output in patients who have cardiac dysfunction. Why would that be? What up there are you affecting that is causing a decrease in cardiac output or stroke volume, or stroke volume? Afterload. I've got a heart that can't beat very well, and now I'm going to put more resistance that it has to push against. So that's where it's coming from. Questions? All right, dopamine, intropic, very common, commonly used drug. Look back at that chart. It's useful because you've got all of this range of dosing that you can use. And look at it over the dosing period. Initially, you're not affecting anything if it's very low, and you want to just affect kidneys, you can use a very low-dose dopamine. As you increase the dose, what do you see start to pop up? Beta 1, right. And then you have to get up pretty high before you start to see alpha. So what do you see under pharmacologic effect? You've got, let's see, you start with vasoconstriction, inotropic, chronotropic, and you keep increasing those effects, with vasoconstriction being the most as you increase, and you can go back and say, I knew that because I see the alpha effect. Look at clinical effect. Cardiac output at low doses, cardiac output, and as that alpha becomes more and more important, vascular resistance goes up. All right. So an inotrope, chronotropic, vasoactive, so it does that vasoconstrictor. Most often uses a second line to norepinephrine, especially in people who have bradycardia or low risk of tachyarrhythmias. Adverse effects, so you can start to look at these and predict them. Increase in heart rate, angina, especially high arrhythmias. All of these can cause an arrhythmia. Headache, hypertension, vasoconstriction. You got these all over the body, so you can get variable side effects depending on what bed is being affected. More adverse effects, less effective than norepinephrine for reversing hypotension and septic shock. All right. Questions about dopamine? Very, very commonly used. Vasopressin, another pure vasoconstrictor. Decreases stroke volume and cardiac output. Add-on to norepinephrine, not a first line. You won't see it as often. Next page. So that's your vasopressors. Now these are your inotropes. So you've got two in particular. Dopamine, you look over on the chart. Again, a fairly wide dosage range, mostly beta 1. Some beta 2, so had vasodilatory effects, small alpha effect. So if you don't need that vasoconstrictor effect and you need more heart effect, dopamine is going to be the one. So increases cardiac output, decreases vascular resistance. So you can still achieve your mean arterial pressure, but it's mostly with what you're doing to the heart. Inotropes, increased force of contraction. Let's see. Third bullet down. Initial choice for cardiogenic shock with low cardiac output, but they maintain their blood pressure. So you can see why. Mostly beta 1. Add-on for norepinephrine. In heart failure, let's see, let me. Okay, I have to work through this one because it's. So in patients with heart failure, the result, which is above, in terms of, well, let's go back to the third one. So an add-on for norepinephrine for cardiac output augmentation. So you can see why with the beta. In septic shock with myocardial dysfunction. Okay? So if you can use the norepinephrine to help with perfusion, you've got that effect with the dopamine to help the heart, or the dopamine, sorry, to pump more, hopefully more effectively. Or when you have ongoing hypoperfusion and adequate volume, and you're using a vasopressor, again, you're using it to augment that part, to make it more effective. So in heart failure, this results in a reduction in cardiac sympathetic activity. Okay, that can be a good thing, because that's usually a driver, a potent driver of cardiac output. Minimal alpha and beta 2 result in overall vasodilation with a reflex vasodilation to increase cardiac output. Okay. Just work through that. That I'm not going to ask you about. It's very complex. They're walking you through the different changes, especially in a cardiogenic shock. So the net increase is your cardiac output's going to go up, mostly because of beta effect, with a decrease in systemic vascular resistance. Blood pressure is going to pretty much stay the same because you're affecting both variables that are sustaining blood pressure. Okay. Arrhythmias, nausea, vomiting, tremors, increases cardiac contractility and rate, can cause hypotension and tachyarrhythmias. They all can cause arrhythmias. That one's a hard one. So look at the big things that it does. Know that it's a positive inotrope. Know that it's mostly beta 1, so it's going to be chronotropic and inotropic effects, and where you're mostly going to use it. The rest of it is just is very detailed in terms of telling you why they're using it in low cardiac output. Okay, the last one. Okay, so let's say this is a cardiac cell. And you have a receptor, catecholamine receptor here that norepinephrine is going to sit on. When it has a receptor interaction, or an interaction with the receptor on the cell surface, remember those big protein receptors we talked about, those GS proteins? They're very large proteins. They usually have an activator associated with them that will convert ATP, which is what in the cell? Energy source, into cyclic AMP. So what do you remember about cyclic AMP? What else do we usually call it? Cyclic AMP, second messenger. It goes on to do other things in the cell. It usually will direct different cellular signaling to take place. So what happens here is when you increase cyclic AMP in heart cells, you get an increase in contractility, you get an increase in heart rate. So usually the work of the heart, it does its work. So what it's supposed to do? It contracts, beats. It can, in other fibers like the Purkinje fibers, it can increase conduction velocity. So all of these things, what the heart does is heavily dependent on that cyclic AMP to do its job. So cyclic AMP is broken down to AMP, and that terminates its activity. And it is terminated by PDE, phosphodiesterase, the enzyme. You've heard of those before. PDE5s we talked about for erection difficulties. So this one are PDE3s. So this set of drugs knocks out that enzyme and increases your cyclic AMP. It stays around longer. Okay? So when you do that, you increase contractility, heart rate, conduction velocity. Now, notice to the side of that with that milrinone is it says it's a non-adrenergic. So what they mean by that is that it doesn't work on that receptor. Some people will describe it as a back door. It gets in through another door, or a back door, to cause the heart to do its work. So it's a way to avoid using a catecholamine. So all the side effects that you see with catecholamines are lessened or not associated with this group of drugs. So milrinone is one of them. There are others, but this is the more commonly used. So it's an inotrope, similar to dopamine. They're often used to treat impaired cardiac function, so you can see why. So if we can help the heart do more what the heart was intended to do than for people who've got impaired contractility, heart rate. We can boost it with this. But we're not going to beat them with a catecholamine to do it. They're short term, so they may be used in an interim while you're getting ready to do something else. So increased contractility is their big thing. Modest increases in heart rate, some peripheral vasodilation. So mostly cardiogenic shock. I did not add them to the other because they don't have receptor effects, and I didn't put it in their pharmacologic effects. Questions about those? All right. Last are the complications. So the big things are dysrhythmias. The other is hypoperfusion. You can switch beds. You can switch where a lot of vasodilation, vasoconstriction is local. So depending on what's going on in the body, you may cause hypoperfusion because you've shunted blood into other tissues. Myocardial ischemia. You drive that heart hard enough and you do not have adequate blood supply, then you're increasing that myocardial oxygen consumption and they'll get ischemia. Local effects we talked about, hyperglycemia we talked about. This is kind of a recap of the big complications with these. Okay, those are hard. Did that help or not? Okay, so I'm going to stick to the big areas of each of those. Be sure you know how they're categorized, what